Hello, everyone, and welcome to today's MinMD Real Talk webinar, Low Testosterone Online Clinic. My name is Austin Hunt, and I'll be your moderator for this event. I work on the marketing team here at MinMD, and I'm excited to be hosting this session today. Also joining the call from MinMD is Karen Bono. Karen will be joining us to help answer any questions relating to MinMD during the Q&A session. Before we get started, we have a short disclaimer that we need to review. The health and medical information provided during this webinar, as well as the questions and responses from the webinar provider, are solely for informational purposes. This content is not intended to take the place of advice or treatment from healthcare professionals. Nothing presented in the webinar is intended to be used for medical evaluation, diagnosis, or treatment. It is not intended to substitute for your relationships with your own healthcare and pharmaceutical providers. Always seek the advice of your healthcare provider before beginning any new treatment or if you have questions regarding a medical condition. All right, with that being noted, I'm pleased to introduce today's presenter, Dr. Brett Mellinger. Dr. Mellinger is a urologist who specializes in male sexual dysfunction, low testosterone, erectile dysfunction, Peyronie's disease, and male infertility, and is located in Garden City, New York. Today he's going to cover the symptoms of low T diagnosis, testosterone treatment options, effectiveness of testosterone replacement therapy, and then hold a live Q&A to close out the webinar. So without any further ado, I'd like to kick things off by welcoming our presenter, Dr. Mellinger. Over to you.
Thank you very much, Austin, and thank those of you who are joining this webinar. As you can see on the screen, this is my training. I've been in practice now for 33 years, and my focus on my practice is male sexual health. So as you can see, I specialize in low testosterone, erectile dysfunction, male fertility, and Peyronie's disease. That is really the bulk of my practice. So this evening, we're going to talk about low testosterone and its replacement therapy. And then when we finish this presentation, as Austin mentioned, we'll have questions and answers to participate. So let's talk about a little bit about testosterone. What is testosterone? Testosterone is a sex steroid hormone, very important. And not only is it important for sexual function, it is important for many other functions in the body. Such as you can see in this schematic of this human figure, it's very important in terms of pituitary gland. The pituitary gland sends a signal to the testis to stimulate your testis to make testosterone. And so the brain is also involved very much with sex drive, mood, confidence, memory. Testosterone is important for muscle health, muscle growth, strength, endurance. Obviously, it's always important for our sex organs. It's important for sperm production, erections. It's involved in prostate growth. It's important in skin and hair growth and collagen growth, and also very important with bones and bone density. And some men who have very low testosterone may have bone density changes. So as one slide says, testosterone is highest during puberty, and then through the age of 20, and then starts to decline as men age. So as men get older, it's a natural decline in testosterone. And then we'll see that there are other conditions which predispose a man to develop low testosterone. So what is low testosterone? This is insufficient production by the testis. And so it may cause increased risk of sexual dysfunction, changes in body composition. The muscle is replaced by fat. There's increasing in waistline, and there's a decline in general feeling, well-being, and energy level. And low testosterone is more common in men who are obese, they have hormonal imbalances, or men who have chronic diseases such as diabetes, cholesterol, or high blood pressure. So any chronic disease condition can lead to low testosterone. So how do we make this diagnosis? Well, we have to look at the symptoms as well as the blood testing. So the two have to go together. So we assess the symptoms of the patient, such as fatigue, energy level, any sexual problems, as well as blood testing. And it's generally accepted for most specialists that 300 is kind of like 300 nanograms per deciliter. It's considered really the low end of normal, in the normal range. And certainly for men under 40, should probably be greater than 400. So there are changes in testosterone and age-related changes. So once we determine that a patient has low testosterone based on his symptoms, the blood testing, as well as physical exam, and if the patient wishes to pursue treatment, then we discuss those treatment options, which we'll review now. So as you can see in these slides, these are your common treatment elements. There are topical gels, which have been available now for a couple decades. Testosterone injections have been around for many decades. Implantable pellets, these are actually testosterone that's implanted in the subcutaneous tissue in the buttock, and they slowly dissolve over time. And then there are natural supplements which may boost production of testosterone in men who have low testosterone, or can be used in addition to testosterone replacement therapies. So let me first mention topical gels. Gels have been around for quite a while. There are a variety of different commercial products as well as the product MedMD has to offer. So the gels are applied to the skin and then they're absorbed through the skin and into the circulation. These work very well. They need to be applied daily though for the best effect. And after application, the man has to wash his hands to prevent transference. You can potentially transfer the testosterone on your hands to either children or your wife or spouse or other females. So it's important to make sure you wash your hands after applying it. And if you're going to be intimate with your partner, you may want to put a t-shirt on to prevent transference, which has also been shown to be effective in preventing that. But again, it has to be done daily and is quite effective. Often we have to raise the dose on patients depending on how well they absorb the medication and what level they're reaching and how their symptoms are improving. Now, injections have been around for many, many decades. They are done at home. This is my own practice. I know some clinics have patients come in weekly or bi-weekly for injections, but I teach patients how to give themselves an injection at home, which I think is more conducive to compliance. It's certainly much easier for the patient as opposed to coming to an office every 2 weeks. So we teach patients how to do this. Typically, we'll use testosterone Cypionate. There's another testosterone product, but my experience is with the testosterone Cypionate, and it isn't a thick oil. So when it's injected, we use a larger needle, 18 gauge, which is a larger needle, to draw the medicine into the syringe, and then there's a fine needle to actually inject the medication. Now, I usually teach patients to inject it in the thigh because you have much more control over it as opposed to trying to inject yourself in the buttock. Also, I have patients put a cold pack on their skin prior to the injection. That numbs the skin up, and quite frankly, the patients hardly feel the needle with the injections. What are the considerations? There are no risks for transfer of this to other individuals. Testosterone levels peak within 2 to 3 days and then gradually decline over the week or two. So whenever I'm assessing patients' level, I like them to get their level after about a week. Because if we get a testosterone level 2 or 3 days later, it's going to be pretty high. So I'm interested in what it is at the end of the week. So at the end of the week, the level is still a little high, then we come down on the dosing. And conversely, at the end of the week, if it's a little low, then we need to go up on the dosing. Skipping or just not doing the doses, what will often happen, the testosterone will drop quite low and patients will start experiencing their low testosterone symptoms again. So it's important to maintain a regimen, maintain on a regular basis to maintain a good level and to maintain good symptom improvement. Now, testosterone pellets have been around for a while. There is a commercial product, and MedMD now also offers this to patients. These are actually testosterone pellets, as you can see in the package, and it is a procedure done in the physician's office. It requires a little local anesthesia, and then a special needle is inserted underneath the skin in what we call the subcutaneous skin, and we'll usually place this in the upper buttock. And then usually the number of pellets will be determined how big the patient is and how he's responded with previous pellet insertions. So the advantage of the pellets is they last anywhere from 3 to 6 months, although in my experience, most patients will have a good level at about 3 to 4 months. The other consideration is there's really no risk of transfer of this hormone to others. The pellets are time release, similar to the body's natural process. There's really low risk for infection or pellet extrusion. It can happen, but in my experience, there's a very low chance of that happening. Also, there's a product with testosterone and anastrozole. Now, anastrozole is an aromatase inhibitor, and what that does, that blocks the conversion of the testosterone to estrogen. So if we have patients who are having high estrogen levels, and this is usually in relation to high testosterone levels, we can add the aromatase inhibitor, anastrozole, which which will block that conversion and then reduce the level of estrogen levels. And that's important because sometimes some patients can develop breast tenderness or even breast tissue if their estrogen remains high. But we don't want to lower the estrogen too much because the estrogen levels are important for sexual desire and bone density. Now, some patients will find benefits in natural dietary supplements. This is often recommended to be used in addition to testosterone replacement therapy. And this particular product was formulated with the help of a urologist and a medical specialist who deals with male sexual health. So it has a variety of products, including DHEA, which is a testosterone byproduct. And 1 pill a day can be used, and many patients will see a benefit with these products. So how effective is testosterone replacement therapy? Well, in my experience and others, we will see a significant improvement in patients' symptoms once they start therapy, and assuming they're on the appropriate dose, be it a gel or an injection. If patients don't really get good levels or are not seeing significant symptom improvement, then we really need to check the levels to make sure that they are getting testosterone levels in a good range. And if not, then we need to increase the dose on the treatment that that patient is having. So successful treatment will lead to higher sex drive, definitely more energy. Patients just feel better, less fatigue. It can also help erection somewhat, although many men will have other causes for their erection problems. But it can help. And there's also some very good evidence that it'll lead to improvement in bone strength. So we'll often get a bone density study called a DEXA scan in patients who have very low testosterone to determine if they have bone density changes. And usually once we put patients on testosterone, after a year or two, their bone density will significantly improve, if not normalize. Also, many patients with diabetes do have low testosterone, up to 40–50% of men with diabetes, again, a chronic disease. And it's also been shown that once these patients go on testosterone, not only do they improve their energy level, sexual function, bone density, they also improve their glucose control. And so many patients may have to adjust their diabetic medication because they will get better glucose control once they are on testosterone. So what are the risks of testosterone? Now, we do mention leg swelling, blood clots. In my experience, the chance of blood clots are extremely low. In fact, several studies have shown that the incidence of blood clots on patients with testosterone is no greater than the general population. But it is concerned, especially if patients have very high levels of testosterone, which also stimulates red blood cell production. So in some patients, the blood can get a little thick. So we always check that on our patients to make sure it's not getting too thick, because that can increase their risk for blood clot or cardiovascular event. But overall, the risk for blood clots is quite low, maybe more concern in a patient who has a predisposition towards that problem. But again, swelling the leg, redness needs to be brought attention to the doctor. Difficulty breathing or chest pain may be indicators of blood clots in the lungs. That, again, I think is very rare. So if any of those symptoms develop, patients need to contact their doctors immediately or go to the emergency room. Now, the advantage of these treatments is they just need to be stored at room temperature. In fact, you don't want to put a testosterone Cypionate in the refrigerator, because that will make it much thicker and more difficult to draw and inject. So you keep these medications at room temperature, and they have long half-lives. They'll last a long time. They won't expire, and they should never use it. So it's easy for storage. Of course, you just want to keep these medications and things in a safe place so that any youngsters in the house don't have access to it or accidentally discover it. Now, it's important, though, after the seminar, if you have concerns about your testosterone or you have concerns about your treatment, that you talk to your physician. Now, over the past few years, in the past, it was considered prostate cancer, testosterone, no, can't do it, because it will cause the cancer to flare up and progress. Well, that has shown to be not true. And in fact, we do have patients now who have a history of prostate cancer who can be treated with testosterone as long as they're carefully monitored with PSA and blood levels as we normally do. So the old idea that testosterone causes prostate cancer is disproven. And in fact, over the last decade, we have many patients with a history of prostate cancer who are being treated with testosterone replacement therapy. We also have patients with prostate cancer who are undergoing what we call active surveillance, meaning that they're being watched very carefully because it's been determined that their prostate cancer is not aggressive and in all likelihood may not lead to their death. So in those patients are also candidates for testosterone replacement therapy, again, as long as we carefully monitor them and they understand the potential risk involved. So which form of therapy is right for you? Well, I tell patients who ask me, which is the best, doc? Well, I can't say one's better than the other. They're all effective, and it really comes down to patient preference. So in terms of topical gels, they're simple, non-invasive, they're effective, but you do have to require some caution in terms of preventing transference, and it needs to be done on a daily basis. Testosterone injections are also very effective. That's administered at home. We teach patients how to do the injection. There's no concern or threat of transfer to others, but it requires injections every 1 to 2 weeks. It says 4 weeks, but most patients will benefit from more frequent injections. And of course, some patients just can't inject themselves and are very averse to needles. Testosterone pellets, the advantage there is they can last up to 6 months, 3 to 6 months. The testosterone is released naturally, no concern or threat of transfer to others. But again, it does the conscious considerations. It requires a minor procedure in the office, a little local anesthesia. Patients say they're a little sore for a day or two. That's about it. But it does require administration by a healthcare professional. And supplements, they're natural. You don't require a prescription. They're over the counter, and they can be used in combination with the prescription therapies for testosterone replacement. So with that, I basically covered the slideshow. So I think we like to keep it open it up now to any questions, and then Austin will monitor that for us.
All right. Do you want to take a chance to talk about the different products that we sent you? Yeah,
you can still see me, right? All right. So this is a applicator for testosterone gel. Depending on what the physicians prescribe will determine how much testosterone gel will be in the applicator. And what's nice, it's really easy to use. So the instructions will arrive with the medication. Again, you don't need to refrigerate it. It's just a matter of moving this top part where it clicks, and the instructions will tell you how many clicks to make to deliver the dose. And then you just scoop up the testosterone, and you're going to apply it to the upper shoulders, upper arms. And usually you will apply some on one side and then on the other. Another place you could apply is on the side of the abdomen. You can also get good absorption on the side of the abdomen. Do not put it on the genitalia. It's not intended to be placed on the scrotum or on the genitalia. Upper arm, shoulder, or the side of your abdomen. And then there's the injection, and which will come in a vial. These don't have any medication in it, but the vials will be like this with a little rubber stopper. And then we have these small syringes for injection, and there will be a larger needle to draw the medicine, because as I mentioned, it's in an oil, so we need a thicker needle to draw it into the syringe, and then we replace that bigger needle with a skinnier needle for injecting it. The skinny needle is really thin with a cold pack over the skin, waiting a minute, and then injecting. Patients really don't feel the needle.
Dr. Mellinger, do you mind holding the vials up a little bit higher? It was kind of hard to see them.
Can we see those now?
Perfect.
Okay.
Yeah, we see them now.
So it depends on how much the doctor prescribes. It depends on the size of the vial. Often we'll prescribe a 3-month supply, and then you don't need to refrigerate the medication. It stays stable for a long period of time. Now, these are what the pellets look like. I don't know if you can see that. So depending on how, these are 100 milligrams. So it depends on what the level is, the size of the patient, what his level was on the previous will determine how many pellets the doctor may want to insert, into the subcutaneous tissue of your buttock. So they look like this. They're sterile, they're in sterile packaging, and then they're placed in a special needle called a trocar, which goes underneath the subcutaneous skin, and then it's inserted into that area where there's a little bit of fat under the skin. So unfortunately, we all have a little fat there, but that's where the pellets reside, and then it's slowly released into the circulation. And then this is the bottle of the supplement that you can get through MenMD. If you do supplements, I would trust MenMD. There's a lot of supplements out there at various over-the-counter places. and all of them will have pretty much, statements about the efficacy or how good it is, and how it will boost your natural testosterone and what have you. So take a lot of that with a grain of salt. It can be helpful, and probably if you are on testosterone, consider a supplement to help boost your natural levels. Also, it's important to consider healthy diet, healthy lifestyle. This is all very important in terms of male sexual health. So certain things, medical conditions, as we discussed, diabetes, get that under control. Weight loss will help normalize testosterone. Exercise also helps normalize testosterone. So all these things together, healthy lifestyle, good diet, exercise, getting your medical conditions under control, reducing weight, glucose control, all that will improve your testosterone level.
Sounds good. I think that's all the products that we had sent to you. So we will go ahead and get started with the Q&A session here. All right, first question. Once one starts to use testosterone medication, do you need to use testosterone medication for life?
Well, many patients who have very low testosterone from chronic disease will be on testosterone for life because the benefits are so great. The benefits in terms of energy, muscle, bone density, diabetics, glucose control. There's also a lot of evidence that low testosterone can shorten lifespan, especially with certain medical conditions. So for many patients who truly have low testosterone or are symptomatic from medical causes, they'll probably want to stay on it the rest of their life because the benefits outweigh any risks. Now, some patients may, if their lifestyle changes, stress is less, their medical conditions improve, their natural testosterone may improve and they may not need to have testosterone replacement therapy. But that requires a lot of effort on the part of that patient to really, improve his health overall. So for many patients, yes, once they go on testosterone, it may be a lifelong thing, a lifelong treatment, because for many patients, once they stop, their testosterone drops and they're back to pre-treatment symptoms and levels.
All right, next question here is related to ED. Is ED always related to low testosterone?
No, it's not. And it's not a common cause of, low testosterone is not a common cause of ED. But if you look at the one slide we had, we mentioned chronic diseases associated with low testosterone, obesity, diabetes, high blood pressure, high cholesterol. Those are also risk factors for ED. So a patient can have those conditions and have ED and low testosterone. Now, once we treat their low testosterone, erections can get a little bit better, but often they need some other treatment because the ED is often due to vascular problems, either poor blood flow to the penis or it's not being trapped properly. So low testosterone can lead to ED. It has to get really low, though, for most patients to be the main cause of ED. And it's not the most common. Other causes are more common causes of erectile dysfunction. But it can coexist with patients who have ED. So that's why in my own practice, I always check the testosterone level when a patient comes in with a complaint of ED.
All right, next question here. What should a good T level be?
The good T level is when the patient has symptomatic improvement and he's feeling good. So we're not just, a lot of patients focus on the number, like what's my number? So I tell patients the number should be in the normal range, but we also have to assess your symptoms. So if you're feeling great at a level of 400 or 500, that's your level. If you're feeling crummy at a level of 400 and we put you up to 600, you're feeling great, that's your level. So I can't say what's the best level. So we have to take the patient as an individual, assess his symptoms and his age, get him to a level where he's feeling good, and then reassess the symptoms. So again, it's important not just the level, but the symptoms. Some patients we'll see may have relatively low testosterone, 300 range. A patient like that today, he doesn't have symptoms. He has good energy level. He has no sexual dysfunction. Well, that's the level where he functions normally, and that's a good level for him. Other patients at that level may not function so well and may be symptomatic. So again, we have to take into account patient's symptoms, age, other medical comorbidities, as well as the level.
All right, next question here. Does insurance cover pellets?
Some insurances do cover pellets, but what has happened over the past several years, they limit the number of pellets if you're going through a commercial product through your insurance. So they usually limit, we have found they limit the number of pellets to 6. So the commercial product was Testapel. Some of you may be familiar with that. So what happened, Medicare and commercial insurances many years ago decided, well, we're only paying for 6. And unfortunately, many patients needed more than 6 pellets to last 3 months. So that's the advantage now of having pellets through MedMD, so that a patient can get additional pellets, even though the insurance may not cover additional pellets, but certainly the cost is not that great, and the benefit is really there in terms of getting good levels with the additional pellets. So if the insurance isn't covering testosterone at all, there's no issue. Then the doctor can prescribe as many pellets as he feels necessary for the patient to get good levels and have symptom improvement.
All right, next question here. Do you recommend TRT after a penile implant?
Well, only if the patient has low testosterone. I personally do a lot of penile implants. I do have a lot of patients on testosterone I've done penile implants on. And again, those are men who often have chronic diseases such as diabetes, obesity, high blood pressure, cholesterol issues. So again, their ED was due to other causes. They could still have low testosterone, and I will treat them. But if they don't have low testosterone, they don't have symptoms, there's no benefit in treating that patient.
All right. Next question here. Actually, next handful of questions here. We got a lot of questions relating to prostate surgery or having your prostate removed or radiation for the prostate. Is there anything else that you want to cover about the prostate and how it relates to testosterone replacement therapy that you didn't cover on the slide during the presentation?
Okay, yeah, that's a very good question, because the slide does say testosterone does stimulate prostate growth to a limit. So what's been shown is, and it's a theory advanced by Dr. Abe Morgenthaler in Boston, who's a well-known expert on testosterone treatment, is what we call the receptor theory. There are receptors in the prostate that are receptors for testosterone, and there are only so many receptors. So once you give a patient testosterone, those receptors are covered, and giving more testosterone doesn't change anything. So the point is, it's been shown that testosterone treatment may initially stimulate some prostate growth, especially a patient who's had low testosterone for quite a while, and we normalize the testosterone. Then we'll see the prostate can increase a little bit in size, the PSA may go up, but that would be a normal response to having a normal testosterone. And so what happens after that patient's on testosterone, the prostate will grow a little bit, and then it'll stop. It'll reach a certain point and it won't grow any further, and the PSA will stabilize. So, and it's also been shown that testosterone does not cause prostate cancer. That is some kind of idea that's still floating around there, especially with some physicians who feel that it causes prostate cancer or heart attacks, and will advise their patient not to be treated with testosterone. And my thoughts on those comments is those doctors are not well informed on this form of therapy or the current information that we have about the safety of this form of therapy. Now, in terms of benign prostate, again, I mentioned it does stimulate a little bit of prostate growth. After a while, that stopped. Now, what about the prostate cancer? Well, if you are actively undergoing treatment for prostate cancer for hormonal therapy, you're not going to get testosterone, because you're on hormonal therapy to suppress your testosterone. And if you go on testosterone, that's going to cause the prostate cancer to grow. Now, if you have a patient who's had prostate cancer and had radiation therapy, that's a different story. We want to wait and see that the PSA levels off, because once patients start treatment with radiation, the PSA will be a little high, and the PSA is going to start going down. And once we see that the PSA is leveled and it's not going up anymore, and it's gone down, has leveled off, then there's a discussion with that patient about testosterone replacement therapy, assuming that would be appropriate for him based on his blood testing and symptoms. And it's just a matter of informed consent and monitoring those patients on a regular basis, of course, the way we normally monitor patients, but especially the PSA monitoring. Now, what if a patient has a radical prostatectomy? If he does well, his PSA is undetectable. And if he has low testosterone symptoms, we're going to go ahead and treat them. At least I will, and many of my colleagues, because the evidence is that in those patients, they do very well. There's no evidence that the cancer can come back from the testosterone therapy. And so it's very safe in that scenario. So with benign disease, patients can be treated. PSA may go up a little bit. It'll then level off. In cancer, patient's been treated. He's not on active treatment for hormonal therapy. After radiation therapy, the PSA levels off. It's been considered safe to treat those patients, again, with the patient's understanding about potential risks, and also with patients who had radical prostatectomy. Those patients can also be safely treated if they're not undergoing hormonal therapy. And additionally, as I mentioned, we have patients on active surveillance. They have prostate cancer, but they're just being watched very carefully. PSA testing every 3 to 4 months, MRI prostate testing. We have quite a few patients in my practice and other physicians where those patients are being treated with prostate cancer. And in fact, in my own experience, the cancer is not progressing, it stabilizes, and those patients continue to do very well with their testosterone replacement therapy, and their prostate cancers continues to be low grade, no rising PSA, and so those patients can also do very well. They have to be monitored closely. You just can't give the patient testosterone and say, I'll see you in 6 months. So we follow those patients every 3 to 4 months with frequent PSA testing.
All right, thanks for that. Next question here. Do you recommend going through all of the treatment options or jumping straight to the more invasive treatment options like injections or pellets?
Again, it's really patient preference. So patients don't have to try injections or gels first. If they want to go straight to pellets, they go straight to pellets. If they want to go straight to injections, they go straight to injections. So whatever the patient whatever the patient preference is, that's the treatment we'll do. And we do have options for treatment. So you don't have to try one and then go to another. But also, you may try one, you may not like it, and then you can do another option. You may want to do the gels and then say, I hate doing this every day, or I'm worried about transfers now that the kids are around. Or you may try the injections and you don't like needles, and then you can go for other options. So you're not stuck with one option once you go down that treatment option, and you don't have to try one to get to another. You can go straight to whatever option you're comfortable with and what your doctor's comfortable with. In terms of the pellets, that's really someone who does quite a few of those. I mean, most medical doctors can prescribe gels, but they're not necessarily putting in pellets because it's a minor procedure in the office. No big deal, but for someone, a urologist who does a lot of these, that's someone who wants doing that. And generally speaking, like I said, the internists aren't going to be offering pellets.
All right, next question here. Do I need to wear gloves to apply the gel?
I don't apply the gloves because, you're going to have probably more end up on the glove than you will on your skin. You just got to wash your hands thoroughly after you apply. That's all. And, that's just common sense. Just wash your hands thoroughly, soap and water. You'll get off any remaining on your hands, and then you'll be good to go. So you don't need to worry about the gloves. That's my own advice to my patients.
All right, I got a question here kind of about cost. I've used the testosterone gel in the past and thought it was effective, but cost and convenience were factors in stopping. Has the treatment cost improved at all?
Well, a lot of the commercial products are costly. What you'll find is that, compounding pharmacies like through MedMD, it's really rather relatively inexpensive compared to what you'll get with a commercial product. Or even if you go to a pharmacy and you ask for testosterone Cypionate and you get that prescription, especially CVS, they can charge whatever they want. And so you'll see the costs go up. But the commercial products for gels are definitely more costly. The Testopel, the commercial product for pellets, are more costly. And sometimes going through the insurance with copays costs more than the actual medication that you can get through a company like MedMD. So I have a lot of patients who find certain treatments too costly for them. Their copays are high. And then I pull up my pricing chart from NMD and say, this is what it's going to cost you. It's going to cost you a gel, $1 a day, $2 a day. Can you do that? $60 a month? Most patients can do that because they're spending more money on beer and cigarettes or other things. So a couple dollars a day for a really good treatment with really good benefits in my opinion, is not very expensive. And the injection therapy is the least costly of all of our treatments. So that's relatively inexpensive treatment option for some patients where cost can be an issue, or they're not even covered for testosterone therapy.
Gotcha. And Karen, is there anything you'd like to add about the cost, at least in how it relates to MenMD?
Yeah, thanks, Austin. MenMD's testosterone gel comes in at $1.30 per ml. So depending on your doctor's prescription as far as your application, Dr. Mellinger was correct. It could be anywhere from $1 to $2 a day for treatment, and we have found that is significantly lower than most insurance copays.
That's amazing.
Right,
The patients will pay more for the copay than you can get the the gel through MenMD. So the insurance companies, the reason the insurance companies just transfer the cost onto the patient. They don't want to pay for it themselves.
All right. Next question here is about anastrozole. Do you mind discussing the role of adding anastrozole to manage high estradiol? I don't know if I'm pronouncing that right. As a consequence of testosterone therapy. Yeah.
Well, a lot of patients will be concerned if their estradiol level is high, but you have to take into account what their testosterone level is. So we see sometimes high levels with injection therapy. It's not unusual for patients after an injection to get a testosterone of 1200. And then, as we mentioned during the presentation, that drifts down after 2 or 3 days. So if we check the estradiol on 2 or 3 days later after the testosterone injection, it's going to be high, because the estradiol is converted from testosterone by a enzyme called aromatase. Now, my own opinion on that is not to drop the estrogen too much, because again, it's very important for sexual desire and bone density. So I won't necessarily treat unless the patient develops breast tenderness. If the patient doesn't have breast tenderness, even though the testosterone will be high, we can look at that a little bit further. We can look at a testosterone estrogen ratio to get a little bit more accurate assessment of that. So that's another way to look at it. So my own opinion is I don't want to depress the estradiol too much unless the patient has symptomatic or develops breast tenderness or gynecomastia in large breasts, which is not that common. That's when I want to treat that patient. But other physicians may have a different approach. But again, when I try to educate the patient, well, your estrogen's high because your testosterone's high. When your testosterone is dropping back down after a week, your estrogen is going to go down. And if you don't have symptoms, then we shouldn't necessarily treat. So that's my own take, although I do have a lot of patients on aromatase inhibitors. So again, you have to take into account patient symptoms. They're concerned about the high estrogen, but my own opinion is you don't want to suppress it too much, because then you can negate the effect of testosterone and improving bone density and the sexual desire.
All right. Does TRT worsen your BPH at all?
Again, that's all old literature. So again, if you're really low testosterone and you do have BPH symptoms, you may see increase in prostate size. It won't increase that much. You may see the PSA go up a little bit, but that'll eventually, level off, because again, I mentioned that receptor theory. The receptors are all covered by testosterone, and given more is not going to change anything. The prostate will reach its growth, and then it may just have natural growth that many have through various growth factors where the prostate can grow. But at some point, that growth won't be due to testosterone. So patients who have symptoms or on treatments, they may progress a little bit. That's not been my experience.
All right. We got a few questions here about long-term use of testosterone replacement therapy around the 10-year mark. Are there any impacts from long-term use of TRT?
There's not been, as far as and I try to keep up on the literature as much as possible in the meetings, the sexual health meetings, what have you. There doesn't seem to be any long-term detrimental effect on testosterone replacement therapy. Again, as long as patients are monitored, levels are within normal range. Now, if you have patients who abuse it, and we see patients like that, they come into the office, they're very muscular, they're bodybuilders, and they're abusing a lot of other things. And some of these patients will have super high testosterone levels. Those type of patients, that situation is not good in the long term, because there will be some problems long term in terms of permanent suppression of pituitary function, permanent infertility, and then other issues over time. So as long as the patient's monitored appropriately, levels are in normal range, we monitor the blood count, make sure it doesn't get too thick. There's no evidence that long-term use is detrimental. And in fact, many patients, as I mentioned, have conditions where they're going to require long-term use. There are certain genetic conditions that lead to infertility in low testosterone. There's a condition called Klinefelter syndrome, where patients have an extra X chromosome, causes infertility, and they have very small, firm testes and very low testosterone. Those patients need to go on testosterone the rest of their life. And the benefit is it'll prolong their life and it'll reverse all those low testosterone symptoms. So I personally have a lot of patients well over a decade. One of my older patients, every time I see him, Dr. Mellinger, I've been on this 10 years now. Is there any issues I need to know about, anything concerns? And it's, Joe, you don't have to worry. Your numbers are fine. You're in a good range all the time. You're not in super ranges. You're in normal ranges, and you're doing great. So I wouldn't be concerned about it. Let's continue. So for the vast majority of patients, long-term use and literature shows continued benefit and no detriment.
All right, next question here. Actually, the next two questions are relating to testicles. So question here is, will my testicles shrink as a result of being on TRT?
They can lose volume. It really depends on the levels the patients get. You know, sometimes we'll see patients on injection therapy get very high levels, or as I mentioned, some patients will abuse it and they'll have very high levels. So what happens on testosterone, that suppresses your pituitary. And so your natural testosterone will go down and your fertility will also go down. So in some patients, we can prevent loss of testicular volume by adding a hormone called HCG, human chorionic gonadotropin. And it's been shown at low doses of that hormone, you can maintain the intratesticular testosterone and so prevent a loss of testicular volume. That's important for patients who are in the younger age or reproductive age, who really are concerned about their reproductive ability and want to maintain a family. And I have a lot of patients like that. They'll be on testosterone. We have them on low dose HCG. And I tell patients, when you want to start having a pregnancy, give me a 12 months lead time to get you back where you were. And so those patients are a little easier to convert, get them off testosterone, get them on something else such as HCG or even clomiphene citrate, and then they'll normalize their levels and improve their semen quality and can initiate pregnancy. And then often they'll want to go back on testosterone because they feel so good on it. So there are ways to prevent that. I'm not so concerned in my older patient. If I got a 70-year-old guy on testosterone, I wouldn't necessarily tell him to be concerned about testicular atrophy, because a lot of those patients have testicular atrophy to begin with. So it really depends on where the patient is in terms of his age and his reproductive potential, so we can prevent testicular volume loss by adding low-dose HCG. And so we can also cycle some patients. We can take them off testosterone replacement therapy, put them on another medication called clomiphene citrate, which raises testosterone, preserves fertility, or even put them on HCG for a period, and then recycle them back on testosterone. So there are ways to prevent that, but again, it really depends on the patient age, his reproductive potential, and his desires. But it does require frequent injections too. With HCG, you got to do that twice a week, as opposed to the testosterone just once weekly. So if I have an older patient, I don't think it should be a concern for that individual.
Okay. And then the follow-up question to that is for someone who said that HCG is ineffective for them. They want to know if there are testicle implants for men on TRT who've had significant shrinkage from TRT.
Well, there are testicular implants. There are prostheses. I assume that's what you mean. But the other question is, if HCG didn't work, what's the dosing? Was it a low dose to maintain volume? How long were you on it prior to? How long were you on TRT before starting the HCG? So if you were on TRT for a while and had volume loss and then started HCG, that's not likely to come back. So the HCG is to prevent volume loss, and we would consider that in someone who has reproductive potential and is concerned about its future ability to achieve pregnancy.
All right. Next question here. Recently, I'm experiencing a lower libido. Are there any prescription medications out there they list a few that they're on, that could impact their T level and thus give them a lower libido?
There are medications that can affect the testosterone level. Not really. Unless, of course, the patient's taking high doses of aromatase inhibitor, and then that may affect it. It may affect it upward as opposed to downward. But more commonly, if the testosterone is dropping, then the patient needs higher dose. And so some patients may metabolize the testosterone fast, and so they may not maintain good levels over a period of time. And so we may need higher doses. The other thing to consider, if patients have really good testosterone levels and the sexual desire, libido's down, there may be other causes. Certain antidepressants can affect libido. Everybody knows that, or should be familiar with that. Unfortunately, there's no specific pill or treatment to give a patient to make his libido better. But as I said, often it's multifactorial. There may be relationship issues. There may be other issues. There may be other medication issues affecting sexual desire. So it's important to understand that if a patient has a really good testosterone level, and I often say to patients, gee, your testosterone 700, my libido's down. I said, that's not from testosterone. So there may be other issues going on in your life. So we look at medication uses, discuss relationship issues. So often, if the testosterone is in a very good level and libido is down, that's not usually due to testosterone. So we need to look at other causes of that, relationship issues, medication issues, to determine if that's the factor causing the reduced libido.
Okay, next question here is asking about getting off testosterone replacement. So how do you get off testosterone replacement therapy, if ever, and at what age is it best to stop, if there is one?
Well, I don't know if there's an age to stop, especially if you have a chronic disease that requires testosterone replacement therapy, as I mentioned, such as diabetes and other chronic disease states. Those patients need to go on it the rest of their life to maintain, healthy lifestyle and longevity. But if for some patients they're still a little low and they're symptomatic, they don't seem to have, chronic disease issues, we can taper patients off. We can put them on clomiphene citrate, which raises testosterone by blocking estrogen. So pituitary sends more signal to your testis. But if I have patients want to stop, I just stop it. See how you feel. We can probably give you maybe some clomiphene citrate. Maybe that'll jumpstart your pituitary and cause more stimulation to your testis. At what age? I can't, there's really no good recommendation on that. It's whenever the patient decides he doesn't want to do it anymore or is not seeing any benefit, then that would be a time to stop the treatment. But for most patients on treatment, once they stop, they're back to pre-treatment symptoms and signs. And so many patients will want to return and go back on their treatment. Some patients will normalize. Their stress will be less. They got better. They're exercising more. They're healthier. And so all those things can normalize testosterone. And so some of those patients may normalize their testosterone and won't need to do replacement therapy. But again, I think you have to consider your lifestyle, chronic diseases, diet, exercise level. If you're not doing any of those things, improving your diet, your health in general, and exercising, you're not going to naturally raise your testosterone, and you may need to go back on TRT.
All right, next question here. Would it be safe and beneficial to increase testosterone and trimix levels at the same time?
Well, again, if that was trimix levels, you said? Trimix? Yeah. No. Well, you want to raise your trimix level if you're not having a good erectile response, okay? So you want to titrate up to a level or maybe get a different formula because, there's a dozen different potent formulas that MenMD has for trimix. And if your testosterone level is low and you're not symptom improvement, then we're going to raise it. So you can do it at the same time if those issues are occurring at the same time. So there's no issue with that. If the erections aren't as good with your current trimix formula, raise the dose, change the formula. And if your T level is not quite normalized and your symptoms haven't improved, raise the dose, increasing the injection, maybe add another click on your gel, maybe add another pellet or two if you're getting pellets. So all that can be done at the same time. It's not contraindicated. But again, the indications will be, are you responding to the trimix at that level? No, then raise the dose. Are you responding to testosterone at that level? No, then we increase the dose or change the type of treatment.
All right, next question here. Does taking testosterone reduce your sperm count?
Absolutely. So for most men, it will. So that's important to consider, and your physician should tell you about that if you're relatively young and in a reproductive age. So one of the questions I ask patients, and some patients may be in the 40s and still considering, starting a family. So my question to the patient is, trying to have a pregnancy an issue for you? Are you planning to have a pregnancy, or is that something anticipated in the future? And patients need to know, why I'm asking that question is because it reduces your fertility. And if that's going to be an issue for you, I tell patients I need 6 to 12 months to get you off TRT and get you on another treatment to get your sperm count back to where you were before you started TRT. But you can't count on it as a contraception, right? If you're on TRT, don't assume that it's like a vasectomy. You're not going to get anybody pregnant. It will lower the sperm count, but some men still may maintain enough sperm that can have pregnancy. In fact, testosterone in the past was studied as a male contraception, and the problem was you didn't see a consistent drop in the sperm count. So it was actually shown not to be that effective for contraception. But it can affect your fertility, so that's important to understand, and your physician should tell you that in addition to all the other potential side effects before you start treatment with TRT, as well as any type of treatment.
All right, next question here. Is there any evidence between cannabis or CBD use and effects on testosterone?
There's no current evidence about that. In the past, there was some issue regarding cannabis and some of the herbicides that may have been sprayed on them before it was legalized, of course, in certain states. And so there was concern that some of these may have estrogenic effects, and that potentially could affect your hormonal balance. But I think right now, with the legalization in many states, it's more controlled. I don't think that's a concern. And there's not a lot of, there was some evidence that it affects fertility. A lot of those studies were done a couple decades ago. So it can potentially affect fertility, though I have a lot of patients from Jamaica. It's a Jamaica thing, man. So they seem to have a lot of kids despite smoking a lot of ganja. So there's not a lot of evidence that it reduces your testosterone level. I've not seen that. It can affect your fertility. There's some evidence about that. But there's no evidence that cannabis can lower your testosterone level.
All right, next question here. Will testosterone help with autoimmune diseases?
I've not seen any studies that show that. Although some patients will have improvement in other symptoms. I had one patient who had neuropathies in his feet. He just had severe pain when walking. So they couldn't do things they like to do, like go bowling or go for long walks. He also happened to have very low testosterone. So I treated him, and subsequently at follow-up visits, he reported his neuropathy was improving in his feet. He was able to do some things. My response to that was a benefit we didn't realize, but I'm glad it's helping. So there may be some benefits that have not been shown in the literature in terms of improving other health problems. But as far as my understanding of the literature and the side effects and the effects of testosterone therapy, there's not a lot of evidence that it can help. Probably can't hurt, but there's not a lot of evidence that that's a good. Adding that will help the autoimmune disease. There's not a lot of evidence for that I see, and no evidence.
All right, we're coming down to the end of the event here, so we're going to ask 2 more questions and then we'll wrap it up. So next question here is, does the effectiveness of testosterone gel decrease over time?
No, it will not, unless that patient's, that patient's body changes, or his medical conditions. He's becoming more obese, or he's not, following a regular regimen. So for most patients, once we reach a dose where they have a good level and good symptom improvement, they maintain that dose. Now, there can be things that can happen in life. Again, very sick, chronic problems can lower that even further. Change in lifestyle, just not exercising anymore, eating poorly, that may affect your level because you can then develop a hormonal imbalance. So for most patients, though, as long as they maintain, healthy lifestyle, diet, exercise, once they reach a good level, that level is maintained. Although, stress reduction can help. Stressful times, stress can also reduce testosterone. So if you're on a good level and who hasn't been stressed out these past year and a half, that stress lowers testosterone. There was a well-known physician in New England. I was at a conference one time, and one of the attendees said, "Doc, what's the most common cause of low testosterone in your practice?" And he said, "Stress. I work in Boston area. A lot of people are stressed out here, all these businessmen and what have you." So stress can be a big factor in lowering testosterone. So if a patient's doing fine and then all of a sudden work stress, relationship stress, that can then lower your testosterone despite having good levels on the previous treatment. So try to do stress reduction, or just raise the level, raise the dosing, increase the dose.
All right, last question here. I'm 79 years young. I use ED pills, but they don't work for me anymore. Will testosterone treatment help my ED, or should I look into stronger ED medications?
Well, if you have symptoms of low testosterone and it's low, it may help it a little bit, but it's not going to be the answer for the ED. So in all likelihood, you're going to need either a different treatment for the ED or higher dosing of whatever treatment you're on.
All right. Well, with that, that wraps up the Q&A session. I'd like to thank Dr. Mellinger for taking the time to present today. And we'd also like to thank everyone listening in for attending this MinMD Real Talk webinar. We hope it was informative and that you'll join us again in the future. If you'd like to learn more, you have a few options. There are more resources in the Resource Center on minmd.com. Visit this page to view instructional videos, guides, expert articles, and much, much more. You can also call MinMD at 857-233-5837 or log into the password-protected secure MinMD portal to schedule an appointment with a MinMD clinical case manager. If you don't have a specialist for your sexual or urinary tract health, MinMD has a new physician finder service. Go to minmd.com and click Find a Physician to get started. I'd like to thank everyone again for taking the time to attend today, and we'll see you at the next one.
All right, thanks everybody.